I want to tell you about a patient of mine. Her name is Carol. Carol is 68 years old, retired nurse. Yes, a nurse. Someone who spent her entire career watching for symptoms in other people. Someone who knew more about the human body than most patients ever do. And yet, for 2 years, Carol dismissed something happening in her own body that turned out to be one of the most important things her cardiologist had ever caught. She called them flutters. That is the word she used when she finally described them to me. Just little flutters in her chest that came and went, sometimes while she was sitting quietly reading, sometimes during a walk, sometimes for no apparent reason at all. They lasted a few seconds, sometimes a few minutes, and then they went away. And Carol, who had spent decades telling patients not to dismiss symptoms, dismissed them because they did not fit the pattern she expected. No chest pain, no dramatic pounding, no breathlessness that stopped her in her tracks, just flutters. She called them a nuisance. She told herself it was stress, or too much coffee, or just the body changing with age. 2 years. She lived with those flutters for 2 years, until she came in for a completely routine physical. And I did a routine ECG, an electrocardiogram, a test that takes less than 5 minutes. And the paper that printed out told a story that Carol had not known she was living. My name is Dr. Daniel Chen. I am a physician in internal medicine, and today I want to tell you Carol's story, because Carol is not unusual. The unusual part was that we caught it. Let us begin. Now, first, I want to explain what atrial fibrillation actually is, because many people have heard the term, but few people truly understand what is happening inside the heart when it occurs. Your heart normally beats in a precise and coordinated rhythm. The electrical signal that triggers each heartbeat starts in a small cluster of cells at the top of the right atrium called the sinoatrial node, or SA node. This is your heart's natural pacemaker. Every beat, the SA node fires. The signal travels through the atria, the upper chambers, causing them to contract and push blood into the ventricles, the lower chambers. The signal then travels down through a relay station called the AV node and spreads through the ventricles, causing them to contract and pump blood out to the lungs and body. This happens 60 to 100 times per minute in a healthy resting adult in perfect electrical coordination. Every beat. In atrial fibrillation, this organized electrical system breaks down. Instead of a single coordinated signal from the SA node, multiple electrical impulses fire chaotically throughout the atria, hundreds of times per minute. The atria do not contract in an organized squeeze. They quiver, they fibrillate. The word fibrillation means exactly that, a rapid, disordered quivering, rather than a purposeful contraction. The AV node, acting as a gatekeeper, cannot pass all those chaotic signals through to the ventricles. So the ventricles receive signals irregularly, and the heart beats in an irregular, often rapid pattern. That is atrial fibrillation, an irregular heartbeat. Now, what does this actually feel like? This is where Carol's experience is so important, because atrial fibrillation does not feel the same for everyone. And in many people, it does not feel like anything at all. Some people experience it as a racing heart, a pounding sensation in the chest that is impossible to ignore. Some experience shortness of breath or lightheadedness or chest tightness. Some feel profoundly unwell during an episode, and they go to the emergency room, where the diagnosis is made immediately. But a significant number of people experience much subtler symptoms. Carol's flutters, a mild awareness of the heart doing something different. That comes and goes, and is easy to dismiss, and some people, a surprisingly large number, experience no symptoms at all. A retrospective cohort study found that 11% of atrial fibrillation cases in the United States were undiagnosed. and the assumed 2-year prevalence of silent atrial fibrillation was 23%. Think about that number. Almost 1 in 4 people with atrial fibrillation may have it for 2 years without knowing. Among patients 80 years of age and older in the ASSERT-3 trial, 1 in 7 experienced atrial fibrillation of at least 6 minutes duration without symptoms, and the population most likely to have silent or subtly symptomatic atrial fibrillation is exactly the population most vulnerable to its consequences: older adults. Now, why does this matter so much? Why is undiagnosed atrial fibrillation such a serious concern? The answer is stroke. When the atria fibrillate, they do not squeeze blood out cleanly. Blood can pool, particularly in a small pouch inside the left atrium, called the left atrial appendage. Pooled blood can clot, and if a clot forms, it can travel from the heart through the bloodstream to the brain, where it can block a blood vessel and cause a stroke. Atrial fibrillation increases stroke risk by approximately 5 times compared to people without atrial fibrillation. Studies show that nearly 8 out of 100 women aged 70 with atrial fibrillation had a stroke within 5 years, compared to about 3 out of 100 women the same age without it. 5 times the stroke risk for a condition that, in Carol's case, felt like nothing more than occasional flutters. And here is the cruel reality. For many people, a stroke is the first sign that they had atrial fibrillation at all. A stroke that might have been largely prevented with anticoagulation medication if the diagnosis had been made earlier. Carol had been a nurse for 35 years. She had taken care of stroke patients. She knew what strokes looked like, and she had 2 years of flutters that she never connected to that risk because she did not know what she was feeling. Now, I want to explain what the ECG showed and why this test is so important. An ECG, or electrocardiogram, records the electrical activity of the heart through electrodes placed on the skin. It is painless, takes about 5 minutes, and produces a paper readout that shows the electrical pattern of every heartbeat in a normal sinus rhythm. The pattern is regular, each beat looking essentially like the last, precise peaks and valleys at consistent intervals. In atrial fibrillation, the pattern is unmistakable. The baseline between beats, instead of being flat and clean, is irregular and wavy. The chaotic electrical activity in the atria shows up as a fibrillating baseline, and the intervals between heartbeats, instead of being regular, are irregularly irregular. No 2 intervals are quite the same. A trained eye looking at an ECG tracing can diagnose atrial fibrillation in seconds. When Carol's ECG printed, I looked at it and immediately knew Carol had atrial fibrillation. Now, there is something important to understand about Carol's case. Her atrial fibrillation was persistent, meaning it was present continuously at the time of the ECG. But some people have what is called paroxysmal atrial fibrillation, where episodes come and go, sometimes lasting minutes, sometimes hours, sometimes days, and then spontaneously converting back to normal rhythm. For someone with paroxysmal atrial fibrillation, a routine ECG done on the day when they happen to be in normal rhythm will look completely normal, and the diagnosis is missed. This is why for people who describe intermittent symptoms, palpitations, flutters, irregular heartbeats, a single ECG is not always enough. Doctors sometimes use longer monitoring, a Holter monitor worn for 24 to 48 hours, or a patch ECG worn for 7 days or longer. A 2025 study found that 7-day patch ECG monitoring during routine health checkups efficiently detected silent atrial fibrillation in individuals aged 75 and older. Silent atrial fibrillation was detected in 5.2% of those aged 75 and older. That is a meaningful number of people walking around without knowing, with a condition that multiplies their stroke risk by 5. Now, I want to tell you about the conversation I had with Carol. After I showed her the ECG, she sat quietly for a moment, looking at the paper. And then she said, "I should have known. I was a nurse. I should have caught this myself." I told her, "Carol, you felt flutters, not a racing heart, not chest pain, not the textbook presentation you were trained to recognize." Atrial fibrillation does not always announce itself the way we expect. And even experienced medical professionals miss symptoms in themselves that they would catch immediately in a patient because we rationalize our own symptoms in ways we never rationalize someone else's. That is human, not a failure. She nodded. And then she asked the question that I knew she would ask, because it is the question every person with a new cardiac diagnosis asks. She said, "What happens now?" And I want to explain the answer to that question because it is the most practically useful part of this story for you now. When atrial fibrillation is diagnosed, the management involves two separate concerns, and it is important to understand them separately because they are addressed differently. The first concern is stroke prevention. The second concern is heart rhythm and rate control. Let me explain each one. The first concern, stroke prevention. Because atrial fibrillation increases stroke risk, the question of whether to use anticoagulation medication, blood thinners, is one of the most important decisions in the management of atrial fibrillation. Doctors use a scoring tool called the CHA 2DS 2 VAS C-score to estimate an individual's stroke risk and guide anticoagulation decisions. The score gives points for heart failure, hypertension, age 75 or older, diabetes, prior stroke or TIA, vascular disease, age 65 to 74, and female sex. Each risk factor adds points, and above a certain score, guidelines recommend anticoagulation because the stroke risk outweighs the bleeding risk of the medication. Carol had hypertension. She was 68 and she was female. Her score was 3, which placed her clearly in the category where anticoagulation was recommended. Her cardiologist started her on a newer anticoagulant medication called a direct oral anticoagulant, or DOAC. These newer blood thinners, such as apixaban or rivaroxaban, have become the preferred choice over older medications like warfarin. For most atrial fibrillation patients, because they are easier to manage, do not require regular blood test monitoring, and have a favorable safety profile. In older adults, now, I want to be honest about anticoagulation because it is not without risk. Blood thinners increase the risk of bleeding in some situations, including falls, which is a real consideration for older adults. The decision to anticoagulate is not automatic or simple. It involves weighing the stroke risk against the bleeding risk for each individual patient, considering their fall risk, their kidney function, their other medications, and their overall health picture. This is a nuanced conversation that happens between a patient and their cardiologist, not a one-size-fits-all decision. But for Carol, given her risk profile, the stroke prevention benefit clearly outweighed the bleeding risk, and she started anticoagulation. The second concern, heart rhythm and rate control. There are two broad approaches to managing the rhythm itself. In atrial fibrillation, the first is called rate control. This means allowing the atrial fibrillation to continue, but using medication, typically beta blockers or calcium channel blockers, to slow the ventricular rate, so the heart is not beating too fast, even if irregularly. The second approach is called rhythm control. This means attempting to restore and maintain normal sinus rhythm, either with medication or with a procedure called electrical cardioversion, where the heart is briefly shocked back into normal rhythm. or with a procedure called catheter ablation, where the abnormal electrical pathways causing the fibrillation are targeted and eliminated. Research, including a landmark trial called EAST-AFNET-4, has found that early rhythm control, particularly in newly diagnosed atrial fibrillation, is associated with better long-term cardiovascular outcomes than rate control alone. Carol's cardiologist discussed both options with her, and given that Carol was relatively young at 68, had a good baseline heart function, and had only recently been diagnosed, rhythm control was pursued. Carol underwent electrical cardioversion, a brief procedure done under light sedation, where a controlled electrical shock restored her heart to normal sinus rhythm. She woke up and her heart was beating normally for the first time in at least 2 years, perhaps longer. She told me afterward that she had not realized how much the irregular rhythm had been affecting her until her heart was beating properly again. She described feeling more energy, less subtle fatigue, that she had assumed was just age. It was not age. It was an inefficiently beating heart, working harder than it needed to move blood through the body, when the atria were not contributing properly. Now, Carol remained on anticoagulation because cardioversion restores rhythm, but does not eliminate the risk of returning to atrial fibrillation. And the stroke risk from atrial fibrillation does not disappear simply because the heart is currently in normal rhythm. The tendency toward fibrillation remains, and anticoagulation remains important. Now, I want to talk about what seniors can do to reduce their risk of developing atrial fibrillation and to catch it early if it occurs. Because while Carol's story has a good outcome, the ideal version of this story is prevention, or early detection before symptoms become a stroke. The risk factors for atrial fibrillation are many of the same risk factors that seniors are already managing for other conditions. High blood pressure is the leading modifiable risk factor. These changes happen gradually over decades, combined with years of exposure to risk factors like high blood pressure or diabetes. They create the perfect conditions for atrial fibrillation to develop. That is why the prevalence increases so dramatically from your 60s to your 80s. Controlling blood pressure consistently and carefully is one of the most effective things an older adult can do to reduce their risk of developing atrial fibrillation. Sleep apnea is another important and under-recognized risk factor. Untreated sleep apnea creates repeated drops in oxygen during sleep. That stress the atrial tissue and promote the electrical changes that lead to fibrillation. Treating sleep apnea with CPAP has been shown to reduce atrial fibrillation burden in people who have both conditions. Alcohol consumption is a relevant modifiable risk. Even moderate alcohol intake has been associated with increased atrial fibrillation risk in some studies, and obesity, particularly the metabolic changes associated with excess weight, is a significant risk factor that in some cases responds to weight loss with meaningful reduction in atrial fibrillation episodes. Now, beyond risk factor management, the question of screening deserves attention because the problem of silent atrial fibrillation is precisely that it is silent. And conventional screening, a single ECG at a routine visit, only catches it if the person happens to be in atrial fibrillation at the exact moment the ECG is recorded. Wearable devices, including smartwatches with ECG capability or optical heart rate sensors that can detect irregular rhythm, have become a genuinely useful tool for detecting paroxysmal atrial fibrillation in between medical visits. Several studies have shown that wearable devices can detect atrial fibrillation with reasonable accuracy in older adults. And multiple cardiology guidelines now acknowledge the role of wearable device detection in prompting further clinical evaluation. Now, I want to be careful about how I present this. A smartwatch cannot diagnose atrial fibrillation. It can detect an irregular rhythm and alert the wearer. To seek medical evaluation, a formal ECG interpreted by a physician is still required for diagnosis. But as a screening tool for older adults who want to know whether their heart is ever beating irregularly, a wearable with cardiac monitoring capability is a reasonable and increasingly evidence-supported option worth discussing with your doctor. Now, let me give you the practical summary that comes from Carol's story and from everything I have explained. First, know the symptoms, not just the dramatic ones: palpitations, a racing or pounding heart, breathlessness, lightheadedness, and fatigue that is more than expected are classic atrial fibrillation symptoms. But also subtle flutters, a vague awareness of the heart doing something different, mild and intermittent, that comes and goes. These deserve to be mentioned to your doctor, not rationalized away. Second, at your next physical, ask specifically for an ECG if you have not had one recently. An ECG at rest is a basic and inexpensive test that can catch persistent atrial fibrillation and many other rhythm abnormalities in minutes. Ask your doctor, "I would like an ECG today. Is that something we can do?" Third, if your symptoms are intermittent, tell your doctor that the flutters or palpitations come and go, and ask whether longer monitoring, a Holter monitor, or a patch ECG would be appropriate to capture what a routine ECG might miss. Fourth, if you have a smartwatch or a fitness tracker with a heart rate irregularity alert feature, take any irregular rhythm notification seriously. Do not dismiss it. Contact your doctor and ask for an ECG to evaluate whether atrial fibrillation is present. Fifth, if you are diagnosed with atrial fibrillation, ask your cardiologist specifically, "What is my CHA 2D S2 VASC score? And what does my stroke risk look like? And should I be on anticoagulation?" These are the most important questions in the early management of atrial fibrillation, and you deserve clear answers to all of them. Sixth, if you have any of the modifiable risk factors I mentioned, high blood pressure, sleep apnea, obesity, regular alcohol consumption, please address these actively, not only for all the other reasons they matter, but specifically because they drive atrial fibrillation risk. Now, let me close with Carol, because I want to end where I started. 6 months after her cardioversion, Carol came back for a routine follow-up. Her heart was still in normal sinus rhythm. She was on anticoagulation. She was monitoring her rhythm with her watch, and she told me something I want to share with you. She said, "Dr. Chen, I spent 35 years telling patients, do not ignore your symptoms. Do not rationalize things away. Come and get it checked. And then I spent 2 years not taking my own advice because the symptom did not look the way I expected it to look." She paused, and then she said, "Tell people. It does not always feel like what they think it will feel like. That is what I am doing today. Carol told me to tell you. It does not always feel dramatic. Sometimes it feels like flutters, and flutters deserve to be checked. I am Dr. Daniel Chen. Thank you for spending this time with me today. If Carol's story made you think about something you have been dismissing, please do not dismiss it anymore. Book the appointment. Ask for the ECG. Let a doctor look at what your heart is doing. And if this video helped you, please share it with someone you care about who has been calling their palpitations nothing. They may not be nothing. Leave your questions in the comments. I read every one, and I will see you in the next video. Take care of yourself, and take care of your heart.